and make those embers glow. I'm on my way, and I don't skip a beat. I can't help it, I've got happy feet. So good, I do what I want and it's understood. There's no stopping me when I'm doing my thing. I'm doing my thing. I'ma do me. You know what I mean. I'm on fire. I'm feeling glad there's a spark in my soul. It up, burning brighter than gold. Yeah, 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 yeah. Whoa. Break it down now. I'm getting happy, feel my heart go zing. I'm clapping my hands and I'm pulling these strings. No stopping me when I'm doing my thing. I'm doing my thing. I'ma do me. I'ma do me. You know what I mean. You know what I mean. Yes, I am. I'ma do me. I'ma do me. You know what I mean. Oh, you know what I mean. Oh, I'm on fire. Yes, I am. I'm on fire, yeah, yeah, yeah. I'm on fire, yeah, yeah, yeah. I'm on fire. I'ma do me. I got happy feet. You know what I mean. I got happy feet. I'm on fire. I feel good. I feel good right now. I'm on fire, yeah, yeah, yeah. Yeah. I'm on fire, yeah, yeah, yeah. I'm on fire. I'ma do me.
Can't nobody hold me down. I'm steady walking like I got 3 commas in my bank account. Living loud, so get your cameras out. I'll probably do the same thing if I was you. Looking at me now, now. Put up your lights and keep them flashing. Don't ever put them down, down, down. Look at me now. Look at me now. Look at me now. Good God, I'm looking sweet. Right now I'm feeling like a slice of heaven, and you wanna sink your teeth in me. And the way that I move my feet, it's like I got this whole world spinning round to the rhythm of my heartbeat. Put up your lights and keep them flashing. Don't ever put them down, down, down. Look at me now. Look at me now. Look at me now. Look at me now. I feel so good. I feel so money. I feel so good. I feel so money. Look at me now. Look at me now. Look at me now. Look at me now. I feel so good. I feel so money. Look at me now. So good. I feel so money. Look
I can't seem to focus, and you don't seem to notice I'm not here. I'm just a mirror. You check your complexion to find your reflections all alone. I had to go. Can't you hear me? I'm not coming home. Do you understand? I've changed my plans, 'cause I'm in love with my future. Can't wait to meet her. And I'm in love, but not with anybody else. Just wanna get to know myself. I know supposedly I'm lonely now. No, I'm supposed to be unhappy without someone, but aren't I someone? You're so handsome, but I know better than to drive you home. 'Cause you'd invite me in, and I'd be yours again, but I'm in love with my future, and you don't know her. And I'm in love, but not with anybody here. I'll see you in a couple years.
It's been a little while since I looked in your eyes and walked that bridge to the other side. Mama says it's gonna get cold in the night, but if I picture you, then I'll be alright. I am ready. I am ready for you to be here. It's been a little while since I held your hand, so my arms won't stretch to your distant lands. Give me every person in the whole wide world, and I'll pick you out in a second, girl. I am ready. I am ready for you to be here. For you, to be here.
Socket grafting, one of the most important fundamental procedure in implant dentistry. One can do it, but not everyone can do it right. Socket grafting in many ways, in its core fundamental principle, is the gateway to more advanced procedures such as guided bone regeneration and soft tissue management. In this highly anticipated live evening session, the dynamic duo, Dr. Sang-Woo Ham and Dr. Chris Lee, will go in depth with different socket grafting concepts and their clinical applications. Open versus closed, resorbable versus non-resorbable, which bone graft material to use, type of sutures, and suturing technique. We want to demystify and clarify socket grafting for you. So if you want to up your game and learn to achieve predictable outcome, this is the session you do not want to miss. As always, the format is lecture, live surgery, and post-surgery Q&A. Take care and see you on Tuesday. Bye-bye. Hello, ladies and gentlemen. How you guys doing? All right, we have already 20 doctors joined this live session. Obviously, this is a very highly anticipated one as well. We do have a special guest, but before I start my live show, can somebody just okay me for audio visual? Just make sure that you guys can hear me. All good? Okay, give me a thumbs up if the sound is good. Scott, how's the sounding there? It's a little bit of a lag. Everybody okay? All right, so we have many doctors joining us from far. Okay, good. We have Josh. We also have joining from Montreal. Okay. We have Peter, the usual suspects. Who's super excited tonight? Who's super excited? Okay. All right. Okay, Scott, Sangwoo you're super excited. Fantastic. We're all excited to learn. We have Jean joining from Calgary, Alberta as well. Chris from Winnipeg. Awesome. So some of you were wondering about this continuing education credit. Okay, I decided to hand out the AGD because Bice Institute Canada, we are registered with AGD. I know it's a pretty big deal in the States. For those of you who like to collect the AGD CE credit. Okay, so the rules of engagement, guys, you need to shout out twice. First, at the beginning of the show. Okay, shout out. What does shout out means? We need to proof of your presence that you were here live, okay, in order to claim a CE credit from AGD. So Mark 1, comma, Vancouver. Okay, that's all you have to do. So your name, first and last name, comma, and the city that you're from. Okay, you need to shout out at the beginning of the show and at the end of the show. Okay, so if you want to get your AGD credit certificate from Bice Institute, shout out now. Okay, please do so. All right, and I will give you a little cue at the end of the show for you to shout out. Okay, you'll do the same thing. And the second criteria is the verification code. Okay, already have a verification code written down here, so I'll present it at the end of it. So all you have to do is once you get that, you just have to email attention grace at Bice Institute, which is info@biceinstitute.com, and then show this verification code, and you'll get the CE credit. Okay, so that's how it works. All right, awesome. Okay, very good. So obviously today we have a very special guest. He's not only a wonderful clinician, he's got specialty in two areas, Perio-Pros. He's from brotherly love city of Philadelphia. Okay, and I've been following him social media for last few years, and I've had a wonderful a conversation with him, and we even had him invited through the pandemic time, a Begin Stay at Home lecture series. So those of you who haven't heard his lecture, I've only heard his one full lecture, but it's already in my top 10 lecture, and its title's called Hopeless Does Not Mean Useless. Okay, so tonight after his presentation, I'll also put his link through a Bice Institute, where I'm going to grant you access to listen to his lecture from last year as well. Wonderful presenter. Love his philosophy because not only he's a fantastic surgeon, but he's also a fantastic prosthetic doctor as well. And he's also a very strong academic. He teaches at a university at a graduate level, and he has over 30 years of experience in a clinical implantology. So that's quite something, right? And tonight's topic is fantastic because tonight's topic is nothing other than the something that we as an implant dentist we dread, which is seeing bone losses, right? I mean, bone loss is sometimes we come to accept it. We all get it. We don't talk about it, but it is reality. But until now, me personally, we really didn't know. I didn't know why we actually get bone loss until recent years. Where the concept of a zero bone loss concept, biological width, emergence profile, and all those things, right? They start to come together, and we now have a pretty good solid understanding. I wouldn't say everything, but enough so that we can minimize the amount of the bone losses. And none other than I cannot think of anybody else to talk about it and present it to our members other than Dr. YK Kim. Most of you've been his fans, just like myself. Follow him on social media, Facebook, and maybe have had a chance to meet him in person. I yet to meet him in person. So tonight is actually going to be my first time meeting in person, even though it's through the screen. So I'm just as excited as much as you guys are. Okay, so let's get into the presentation mode. All right. Okay, I'm just going to go picture in picture. Okay, so tonight the topic is minimizing crestal bone loss, right? Obviously, and it's already episode 21, believe it or not. Some of you guys were asking what happens to the other episodes. Well, I take it down after about 1 or 2 days. I take it down, and these are all going into my vault, and I will in the future put all of the series together, and I will make it available for future viewers, okay? But for now, it is a limited viewing for those who are viewing live and also have unlimited access for the first 24 hours, okay? All right, so Dr. Kim, what can I tell about him, okay? He's very legit. He lives in Philadelphia, Pennsylvania, and he had a degree, dental degree in University of Sao Paulo, Brazil. He had a dental degree there, but he also went to University of Pennsylvania and received his dental degree there as well. So he's got 2 dental degrees from 2 different universities, right? And also he had specialty training in periodontics and implantology, and he is an assistant professor at Restorative Dentistry as well as a professor at the graduate periodontics, okay? And I highly recommend that you follow his other posts, right? Look for it in Facebook. He does a wonderful, extremely meticulous clinical work as well. Okay, so no further ado, what I'm going to do is I'm going to change my scene so that I can actually invite him into our coffee show session here. Dr. Kim, are you there? Let me just make sure that your volume is okay. Let me hold on. Hello? Can you hear okay? I cannot hear you. Hold on. Okay, I need to. Hello? Hold on a second.
I think I'm muted now.
Oh, okay. I'm good. Okay, now I can hear. Can everybody hear Dr. Kim?
Okay. Great.
Okay, everybody good?
Hello, everyone.
Okay, I can hear them. I think these guys. All right. Okay, Sangu, can you guys hear Dr. Kim? All good to go?
Hello.
There's a little bit of a lag. So let's just make sure. All right. Excellent. So I think our audio visual is all good. Okay. Josh, they said I can hear. Sangu, can you hear? Can you guys hear okay now? Paul? Sangu, all good? All good to go? Okay, I think they can hear. Okay, so let's welcome everybody. Dr. Kim from Philadelphia. So what's the time zone there right now? It's a little earlier, right?
Believe it or not, It's a very early, 10 p.m. Sunday evening.
10 p.m. Okay, so that's actually quite late. 10 p.m. So we are 7. So it's 3 years ahead. It's like a Toronto time then, right? So okay, yeah.
Right.
So
Yeah.
hopefully,
3 hours difference.
we
Yes.
really appreciate you joining us for the Late Night Coffee Show, episode 21. As you can see, so many of the members are already joining live. It's a hot topic. It's a great honor to actually see you, not in a real person, but also see you, face to face like this here. I know we chat a lot on the phone and things like that. But it's fantastic. So
Yes.
our members, I really appreciate your giving up your precious weekend time of a Sunday rather than spending with your families. Decide to spend with us. So I really appreciate. Okay, yeah. So Dr. Kim, tell us
It's
a
a pleasure.
little bit about yourself. I've introduced you, but I think there's still some members in our group who want to get to know
Yes.
you better.
Yes. Thanks for kind introduction first. Yes, as you mentioned, I was born in South Korea. In my early age, around 9, 10 years old, we ended up moving to Brazil, South America. That's where I was raised. And if you haven't been in Brazil, in South America, everybody look like me. So all my education was done in Brazil, including dental school, graduated from University of São Paulo. And then we went through a second immigration. We ended up coming to Philadelphia in search of American dream. And, I can humbly say that America was wonderful for us and trying to check back a little bit of what we achieved living in America for quite some time. Went to University of Pennsylvania in Philadelphia in 91 and never left. Went through as a dental student, as a perio resident, as a pros resident, as an assistant professor restorative and undergraduate clinic, through perio, now graduate periodontal prosthesis, assistant professor ranking. It's been a day at school, sharing a little bit of experience we have, but more than that, learning a lot from the residents and from the colleagues and all. I do 4-day practice in just outside of Philadelphia, small, humble general practice. I proudly say that we highly specialize in general dentistry, believe it or not. Yes,
It's
yes,
like a full
yeah.
circle, right?
I
Full
think, I
circle.
think exactly. So I think I'm the only one who practice specialty of a general dentistry, and we are doing relatively okay so far. Yeah.
I mean, that's
And
very
today, I
interesting. Yeah.
thank you for the invite and Biting Institute. I love the group. Again, I haven't had a chance to meet members personally. You and I first time face to face, but looking forward to one day, an opportunity for us to meet face to face.
For sure.
And again, thanks for the invite, and I'll try to share a little bit of experience we have, and hopefully my colleagues from East Coast Sunday night joining us, and members from the West Coast. Hopefully we make this a short time, but hopefully we make this productive
Absolutely.
and spent well worth it for all of us in here. Yeah.
That's great. Because it's the first time I'm meeting on the screen. This is a tradition that at the LCS, late night coffee, this is what I do. I have to kiss the guest, okay? There you go, okay? There you go. You guys seeing that, okay? That's on the film now. All right. Okay, you members, you saw it, okay? I kissed Dr. Kim, okay?
For a half second, I thought about should I turn my face, but I held it back.
There you go. Okay. Don't get my lipstick up there. Okay. All right. So what we're going to do, we're going to switch over the screen and then we'll start the presentation. Okay. Hold on a second. Let me change the scene
Great.
again. All right. I'm the one-man show right here. Okay. Here we go. And I am going to put this right over here. All right. Okay, you guys, dear members, you guys are in for a treat, okay? This is Dr. Kim,
All right.
dual specialist, Perio-Pros, but also fully understand the scope of general dentist, okay? He's highly, highly specialized. So we're in for a treat, everybody. Okay, shoot some heart, okay? Appreciate, and then let's give Dr. Kim a warm welcome, and then let him begin. Okay. Okay. Take the mic, Dr.
All
Kim.
right, great. Great. Thank you. Thank you again. And hello everybody again. Um, at any time I have an opportunity to share material we have, I never fail. My first slide is what you see, get inspired. It's not mine. Actually, it's a title slide from the conference in '95, I believe. No, 2005, I believe, or somewhere there, was in New York City. It's the first World Congress sponsored by AstraTech. When AstraTech first came to US, their first world meeting in America was in New York City. And on that day, on the first day of that meeting, I get into that Hilton Hotel on 6th Avenue in New York. And this humongous ballroom, there is a title slide in the front welcoming, and their slogan on that meeting was "Get Inspired," and that word came to my heart as a bomb, as an awakening message, and I fell in love. And purpose of sharing this slide with you is not for you, any one of the members who are present here, to get inspired by what I have to share, but that's the history background of it. And I think it's something that we as a pros and colleagues, we inspire from each other, inspire our colleagues, and learn from each other, sharing the experience. And exactly that's the purpose of what we are doing today. And title today is to actually, the material I'll be sharing today is very, 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 very small portion of material that I present in my one-day course. So in our limited time, I shrunk that down to as much as I could and limiting to most significant aspects of it. And the material is how to treat peri-implantitis. And if we move on, I'll give you the answer to that question, how to treat the peri-implantitis toward the end of my presentation. But Dr. Kwan, let's move to the next one. And one thing that I try to keep in my mind, and I have two boys, and I keep telling them over and over, and this is a message that should be applied in my professional life, not only but in personal life, that wrong is wrong, even if everyone is doing it, and right is right, even if no one is doing it, right? So not true. Because everybody doing it, that's the right thing to do, or vice versa. So one picture that I shared with you that comes from a magazine, dental magazine that we all receive, and I'm not disclose a name, but this is a marketing page of a very, very well-known laboratory in US. And as you see here, 014 hybrid bridge, and I think no one can deny that the quality of a finishing and aesthetics and all. But one thing that very often we miss, and I think I won't be wrong if I say majority of us probably didn't pay much attention to that, is the intaglio surface of this, where the implant is, and the tissue contacting surface of this hybrid, beautifully fabricated bridge. As you see on the Pontic side, this is a complete ridge lap design, that there is no way of one accessing intaglio surface of that for proper hygiene of it. And as we go to the next one, you see one picture. This is a picture from Grand Canyon. Actually, it's an area that my family and we are looking forward to visit next month, actually. And as you see on the top picture there, what most people see here is this beautiful, with a grandeur scenery that nature has carved on its own. And every year, as you and I know, hundreds of thousands of people go there and taking selfies and pictures and all that. However, on that fence, a welder sees something completely different that no one who get to visit Grand Canyon pays attention to. That is how that metal bar is sold or how it's finished in, right? So we as a dentist looking at that beautiful drop, that a gorgeous, beautiful hybrid bridge, is not how the tooth color was stained and carved and sculptured and how beautiful that soft tissue pink was designed. But there's a lot more than that you and I as a clinician should pay attention to as we evaluate and provide the care. So as we go to the next one, peri-implant bone loss that we deal with every day in and out in our office. What do we really know about that is what we want to discuss a little bit today, okay? And we've been practicing dentistry for some time in a small city here in Philadelphia, so-called the city of brotherly love. And to be honest, at this day and age, I'm not sure how brotherly love, how much brotherly love we have in our city. But that's my office, small office we have outside of myself, and I have a full-time partner. Both of us practicing general dentistry. And on the right side is a picture from New York City. My family, we visited New York City, and that was celebrating my second anniversary of my 26 years old. Yeah.
Oh, wow.
So that's my life, and good enough is enough. That's my practice philosophy. Okay. And was never, and is not, and it never will, at least in my practice, that making it perfect will never be our goal, but making something that is good enough. If we can achieve something that's good enough, provide a care that's good enough to our patients, I'll be very, very much satisfied with that. During my training, my career, I was fortunate enough to meet many of highly qualified mentors, and most of them, or I would say many of them, taught us saying that practice makes perfect. Practice makes perfect. Probably we all heard that. And one mentor in particular, who's no longer with us, insisted that no, that's wrong. Practice does not make perfect. Perfect practice makes perfect. And he insists on us that our practice should be perfect. Do perfect practice. But today, sharing a little bit of we know with the students at school, with before in the past, dental students, now with the residents, I say that with all due respect, I do not agree with that. I don't think that practice makes perfect. And I don't agree that perfect practice makes perfect either, because I don't think there is one out there who can do perfect practice to make it perfect. But I have my own version of it that I share with students when I have an opportunity. Is practice does not make perfect, but practice makes us better, right? Better, right? Today, hopefully we'll be doing better than what we are doing today. And who are we to make it perfect? As far as I'm concerned, and I need to be careful to be politically correct this day and age, but only one, the God Almighty, is the one who can make it perfect. Right? Who the hell the YK Kim is to make it perfect, right? But if I can make it good enough, I'll be very, very happy with that. Now, the getting back to the basic of it, this is what we learned at dental school. Unfortunately, it's so basic that we don't talk about it, right? That when we face a patient or a tooth, one surface, one pocket, one screw, we go through diagnosis, which is the identification of the problem. We go through the finding the etiology, which is the identification of the cause of the problem, right? And treatment objective is to eliminate the cause. If I eliminate the cause, I solve the issue, right? And the treatment plan comes at the very last part, which is how we are gonna do that, right? How we are gonna do that. But unfortunately, many times what we do today is we look at the patient, we look at the one tooth missing. Immediately what we talk about is, do I need the bone graft? Do I need the socket graft? How many implants and what size of implant? We are doing the treatment plan already, skipping entirely basic, but so basic that's so important that often we ignore is one of the reasons why we get into trouble. So as we move on, we are talking about implant dentistry. And my definition, my objective of maintaining or creating or achieving successful practice of implant dentistry is not necessarily try to find how to make it successful. But the definition of successful in my mind is that if I can create an illusion of reality, as we see these two pictures side by side, exactly the same patient, and we are focused on tooth not number 8, but here I should say number 11, right? Number 11. That the central incisor, which is periodontally compromised and deemed hopeless, we replace that with an implant. And what picture we see that is a provisional restoration, as you see in the radiograph. But if I don't mention that, if I just throw this picture on the right side out there, and if I ask what you see, very unlikely, I think that one will suspect that this is a temporary restoration supported by the implant that came from a tooth that was once compromised, as we see on the radiograph in there, right?
That's impressive.
So if we go to the next one, and here's a picture that in the Bikes Institute page, I get to see the game Dr. Kwon and Adam is here posted there. What do you see? How many implants in there? What is the implant at all? And I ask you here, if you look at it here, who can tell how many implants are there? Right? And how many are natural teeth, and how many implants are there? And if there is an implant, which one is it, or which ones are they? And I can assure 99.9% that majority of us will not get the answer right. Will not get the answer right. At least on this picture. Majority of us, I would say, right? And I said that there are 2 implants in there, 2 implants, and the implants are number 12, and number 22. Number 12 and number 22, right? But that's the point is, we created an illusion of reality that real enough that patient will accept as a decent, acceptable care. In other words, it's not perfect, but it's good enough. It's good enough. And if I can make something good enough for our patient, I'll be very satisfied with that. Now, there are many aspects of implant and the patient itself that we need to analyze during the basic phase of it, the diagnostic phase of it. And of course, today the purpose is not to analyze and discuss it that, but one most important thing also is not what we do as a clinician, but what patients do as a patient, which is they need to do their share of cooperation, and their expectation has to be reasonable, realistic enough, right? And as we go, to achieve success in implant dentistry, there are many different aspects, not only surgical side of it, but there are aspects of prosthetic side of it, and both has to be in synchro, in harmony, for us to achieve a symbiotic outcome. Doesn't matter how wonderful surgeon you are, and if you as a restorative dentist does not reach that level of proficiency, or vice versa, very unlikely we are going to succeed treating the case. So success in implant dentistry is not every case is for implants. Not every case is for implants, right? Many patients come to our practice, or even during the hygiene visit, as they fracture one tooth and they're losing one tooth. Very, very often they bring the implant as an option, and many times I really, really struggle to convince them implant is not the best care for you, right? And from our side, it's a result of a synergy between surgeon and the restorative dentist. And we need to be ready to accept a compromise, because again, at least in our practice, we don't aim for perfection, but something that is good enough. When it's good enough, it's enough. I'm not gonna put my patient for second surgery and third surgery and fourth surgery to make that, let's make that 0.5 millimeter black triangle better, right? Only you and I can see that 0.5 millimeter black triangle, right? Unless we point out, we know majority of the time patients are not even aware of it, right? And forget about the shade match. I'm looking at the central incisor. I mean, the color is completely off, right? And when they bite down, that's the only tooth they are biting. How does the bite feel? Oh, feels perfect. Feels perfect. You look at the shade, and it's good enough for that. It may not be perfect, but I don't think it's right, and I don't think it's worth it, and I don't think is respectful enough to the patient, dragging that one tooth restoration 3, 4, 5, 6. I haven't seen a patient going through over a year for one tooth restoration, and I'm not sure if that's really right. But anyway, point is not to be sloppy, right? Point is not to be sloppy. Point is to make it good enough, right? And in implant dentistry, as far as I'm concerned, as far as a predictability of the implant treatment, if we go to the next one, I don't feel that there is a single case that I can predictably guarantee that this is gonna be successful, functionally, right? Phonetically, aesthetically, and in every aspect. I'll guarantee you this is gonna be perfect. I don't think there is one single case that we can go for that. Because one factor, most important, is case selection. If this is case for implant or not, if it's the case that we are gonna have a decent, acceptable outcome or not, and if it's not, what type of compromise we will be facing with during and after, and being prepared for that ahead of time, not trying to manage that after facing that compromise. Okay, so if you look at one case in here that we treated many years ago, 75 years old patient came to our office with request, I need implants. Okay, where? Right here, lower anteriors. What else? I'm fine. I need implant here, lower anterior. And I said that I would love to do the implant, and I would love to give you what you want, but I'll tell you right now that you must not have implant. And I'm sorry, but I'm not gonna do the implant for you. I have a different solution, different suggestion. And if you accept it, that's wonderful. If you do not accept it, if you insist on implant, I think you have to go somewhere else to get implant done, because I'm not gonna do the implant for you, because from what I know, you are not a candidate for implant. And after spending time explaining reason why I say that, we end up treating this patient other way, and this is the outcome that we achieved. And we end up reconstructing this patient as full mouth rehabilitation. Yes, if the implants came on the upper posteriors where are edentulous, but right here in the lower anterior where he came with request of implant, that's what he wanted to have replaced. I declined, and we end up giving him something else, and I'll show the radiograph of the case now for you to see what we end up doing here. As you see, we give the implants on the posteriors, but the lower anterior where he requested, I declined, I denied, I rejected, refused to the implant, but we replaced the lower anteriors with the conventional two-supported bridge. And if we go back again for the close-up of what we did, and as you see from number 33 to 43, there's a 6-unit bridge with the 14 sizes of Pontic, and you don't see the black triangle because we built there's a pink porcelain. And I think you all agree that if had I placed 4 implants in there, 2 implants in there, 3 implants, I don't care, it's 3.5, 3.2, 3.0, whatever it may be, I doubt it that we can achieve a result we have here. Had we placed the implant in there. That's the reason why I told him, you are not a candidate for implant. There is a better way of doing it. And of course, as we see, occlusion is a problem, that there is, vertical dimension is closed. There are a whole lot of issue going on that after many hours of educating, informing, and for him to realize that there is something more than, missing teeth in the lower anteriors, we treated him in a very different way that satisfy the needs of a function and aesthetics. So having said that, today, implant dentistry, where we are in 2021, and actually here there is an error, it's not 35 years of experience, but it is a 39 years of experience. What we learned from 39 years of experience. And that 39 is not from my experience, right? The implant dentistry in North America today in 2021, we celebrate 39 years of a clinical practice of implant dentistry, right? Professor P.I. Brannemark started with the dental implants in 60s.
Yes.
And he built many years of clinical and histological data. And in 1982, there was a conference in Toronto, not in US, but in Canada, in Toronto, organized by ZARB. That meeting was the one that many prosthodontists and oral surgeons were invited. That was the very first time that implant dentistry, as we know today, as endosseous screw-type implant was introduced to America.
Yeah, very monumental event. Yes, right? Absolutely.
So we have been practicing from 39 years. What have we learned? And a question I ask myself, did we really learn? Meaning, do we know everything about it? Right? Because had we learned everything, if we knew everything about dentistry, if we go back to the picture now, that we wouldn't see a picture like this, right? Situation like this.
That's right.
after 39 years, right? 39 years. As we know, we don't care how many years implants or any product, any technology, or whatever it may be, was used and developed in Europe. Unless that is approved in North America, really, the final endorsement really comes from North America, right? Canada and US has to approve it, and we as a North American need to use it for that to have accept a seal of a validation to be used in worldwide, right? So after 39 years, why do we see something like this? By the way, this is not my picture, but I spend a lot of time on Facebook and I share
Looks like
my
my
humble
picture.
case.
Looks like my picture.
I erase your name there.
Looks like my cases.
I got this from Facebook for someone else, right? And actually, this case was used for my company as a marketing case. But as we see here, of course, we don't need to be a rocket scientist to diagnose this as a periimplantitis. But it's not the way. The important part of it is not diagnosing this as periimplantitis. We all know there is an infection in there. We all know there is a bone loss in there. But question I have is why and how we got to this point, right? And when we see cases like this, what we very first do is taking periapical X-ray. And as we take the periapical X-ray, we will see the bone loss, right? And as we see the bone loss, we say, wow, you have bone loss on implant. Your implants are infected. You have a periimplantitis. And unfortunately, today, 2021, you need a laser. Laser is a magic wand, right? Solve everything. So you need a laser. But the way I see this is on my own way of interpreting this, at least based on my cases that end up turning like this. The pathogenesis of the progression of the lesion of periimplantitis does not start from inner proximal area where we get to see bone loss on our periapical radiograph. The bone loss starts from the midfacial, not, of course, you cannot generalize and everything. Bone loss is going to start on the mid-buccal, thinning out the buccal plate, and that begin creating an irritation on soft tissue, that the very, very thin soft tissue contacting contaminated metal surface, and that inflammation infection now begin to wrap around the implant. Now we end up losing the bone in the proximal. That is the time we get to see bone loss on periapical radiograph, not before that. So you could have an entirely compromised mid-buccal surface, the implant, that on the radiograph is going to show as a perfectly healthy implant, correct?
That's right.
So as we move on, the cases of periimplantitis, this is a case of my own, but not my implant, but somebody else's. Not that I don't have my own implant. This patient present this implant this way. How would I treat this case today? How would I treat? Probably majority of periimplantitis cases today, I treat them. You may not agree, but majority of them, I treat them today. Let's remove it and start all over again. Right?
It's the only sure way.
Somebody had asked, can you give me some techniques, some material, some instruments, how to treat periimplantitis? And I answered, I was given actually 3 hours to lecture about that. And I finished the lecture in 1 minute. And I give the answer right now in 1 minute. And if you want, we can talk about something else. But if you are here for that answer, I'll give answer right now. And that answer of mine is, we have so many different instruments and technique and different acids, decontaminants and everything else. And as far as I'm concerned, they all work or none of them works. Right? There is no one technique that one can assure me you do this way and you'll be successful 100% of peri-implantitis treatment. I don't believe on that. I don't believe on that. Right? So it's I would say that if you are lucky, you're gonna get a very good outcome. If you are not lucky, you're not gonna get it. Right? If I use a tie brush and this case work perfectly, that doesn't mean the next case gonna work perfectly.
Exactly.
So there is no really predictable way. And in our private practice, one failure is too many. One failure is too many. So today, situation like this, yes, I have done. Yes, you treat the surface with, whatever the chemical out there, and you do the mechanical debridement. One thing that I have not done is using the laser, other than diode laser, because I don't have a laser. And at least for now, I don't have an intention of investing on a laser yet. But if I were to treat this case today, I'm gonna remove those implants and start all over again. And I'll share with you why I say that.
I think if I were to say because I have a laser, $130,000 laser, Perio-Laser, the only they say FDA approved thing, but to be honest with you,
Correct.
it's still not predictable. Still not predictable.
Absolutely.
Yeah.
It's not that it doesn't work, right? It's not that it doesn't work. Absolutely, it has a value.
Yeah. But it's not predictable enough to guarantee the patient, because what patient wants a solution, right?
Absolutely.
And I cannot say you spend that money, because I have to charge significant enough of money, because I'm spending a whole hour to go through all that process of laser and all that and all this. And what I have an issue is that if I cannot look in their eyes and say that this is going to work, because I hate saying it may work, it may not work. But if I can spend the same amount of time, Dr. Kim, I can remove that implant in 5 minutes and place another one in there. I have a higher chance of being confident than try to go in there and salvage their existing contaminated implant. So that's my take as well, right? I'm not saying, like you said, it doesn't mean that it doesn't work. I mean, some of the members say, well, how about 3-wall defect versus 4-wall defect and all this? Yeah, sure. I mean, those play a certain parameter, right? They will influence it. But the bottom line is these implant surfaces are so hard to clean to make it 0% microbial. I throw a kitchen sink in there, that I've done the sandblasting, I've done the peroxide, I've done the tetracycline, laser, all that stuff. But there is no guarantee. There's absolutely no guarantee, and it's a 50-50 at best. Say situation is. So, yeah.
It's going back to the case selection, but I see that. You know what? I'm spending so much time talking, and I'm only quarter way to it. So let me speed up a little bit. So if you look at these two cases, right? One is a fresh extraction socket, and other one is an identical surface, a real ridge. I'm gonna treat this very, very differently, right? I'm gonna put exactly the same implant. I made the place the same implant, but I'm gonna approach very, very differently, and that's what I'm willing to share with you. And on the next one, we see probably you have seen pictures like this all over the place. Is what happened to that buccal plate in extraction socket, for example, right? We all know that. We all know what's gonna happen with that. That woven bone, and we have all the literature and all, but. Is that bone? Can we prevent the resorption of it, or can we minimize it? Right? We talk about the thickness of the bone and the width of the gap. Do I graft inside? Do I graft outside? We focus a lot about hard tissue level, but does soft tissue matter? Does it matter? And as we go, we'll see that. One paper that I shared with you, which we all know the name, right? The one that started talking about soft tissue, Thomas Linkevicius. And initial gingival tissue thickness at the crest may be considered as a significant influence on marginal bone stability, right? If the tissue thickness is 2 millimeters or less, crestal bone loss up to 1.5 millimeter may occur despite the supracrestal position of the implant above the interface. So we talk about that, micro gap and biology width has to be up, down, and all that. But according to his paper, at least with this 1 year follow-up, that micro gap is really doesn't matter if the soft tissue is thin, you're going to have a crestal bone loss. So I'll show you some of what I experienced in my office. So if you look at this case in here, as you see, the number 34, right? No, 40.
44? 45?
45 and 46.
46, yeah.
So 46, as you see the soft tissue there, is an existing implant. By the way, periodontist treating this patient is a mentor of mine, very, 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 very qualified periodontist, right? And I'm working here as a restorative dentist. So as I'm looking at this patient, number 46 is an existing implant, existing tooth, and that's what we see clinically. Tooth number 45, I just restored. It's an implant also. That periodontist place, I just restored that. And as you see, we go to the next one, you see the soft tissue, the surrounding area is very different. Tooth 47 and the 44, which is a natural tooth, as you see the quality of the soft tissue and the root eminence compared to the implants on 45 and 46. And let's move on. As you see, the reaction is very different. And if I share with you the radiograph of this case now, you get to see from 2013, you see the periapical radiograph of a 45 and 46. Now, 15, 16, and now to 19, you see that there is really no significant difference, right? Yes, there is some, but not a significant difference in the radiograph over 6 years period in there. But clinically, I don't care what radiograph shows, I can guarantee that there is bone loss on the mid-buccal of this implant 46.
For sure.
Right?
Yeah.
Although the radiograph shows perfectly fine or almost perfectly fine, right? So what is happening here is what we saw before. Then I'll show you again the picture. This tooth number 46 exactly give you a little more time, and this is exactly what we'll be facing. The bone has been lost on the mid-buccal, and soft tissue begin to react. That inflammation slowly is going to progress, wrapping around the implant. Once it reaches the inner proximal area of it, that is what we'll end up facing. Once it wraps around, get to the inner proximal, from that point on, it's going to go downhill very fast. So how we manage the mid-buccal is very important. So we have a bone, the lingual cortical plate and buccal cortical plate. In early stage of implantology, we used to advocate bicortical stabilization. Implant goes in there, has to engage the buccal cortex and lingual cortex. That's how we get the solid stability of it. Today, that's a no. So because what happened, as we do that, we end up drilling out all the metal surface and leaving the cortical plate around the metal of the implant. By removing the metal surface, we got rid of all the blood supply. We all know the cortical plate, there is no blood supply. You put the metal that is non-vital against the cortical plate that there is no blood supply, guess what's going to happen? Matter of time, that bone will dissolve and goes away. Once the cortical plate disappears, now you have a thin soft tissue around against the implant, and that's what we'll be facing. So as we go, and if you look at this case here now, this is a case of mine, is an overdenture case. And if you look at the upper picture there, what you see, the grayish color through the soft tissue is exactly what we're talking about. The buccal plate is gone. Now implant is showing through the soft tissue, but on the radiograph, there is a very, very minimal loss in there. So if we try to diagnose health of this implant based on the periapical, we are doing something not good enough. Not good enough. So as we go, how we manage it today, this is a case of mine, as you see, missing partial identism in the lower. I'm gonna maintain the upper, the posterior true teeth that we have, 36 and 35, and I'm gonna place 3 implants in there, as you see here. We're gonna place 3 implants, and we submerge implants because I do my best not to immediate loading. And that's a totally different issue, but that's not the point here. So the reason why they submerge, by the way, you gotta agree with me. This is a very, very nice closure in there, right? It's a very nice suture. You gotta agree with me.
That's an incredible
every time I
suture.
look at this reminds me of football, you know. But
So
anyway,
Yoshi.
the point is the middle implant where I'm pointing there is placed too far buccal, too far buccal. As you see, there is a very thin buccal plate remaining, and we submerge that, and let's see how we restore this case. As we go, we uncover that, and we treat this with the locator abutments, and over time, we are monitoring the 1-year-old now, and some supracrestal, supragingival plaque, but overall pretty good. But as we go along, on the radiograph, pretty decent. That's exactly what I expected. But this is a 1 year. Now, if we look at the 5 years now, what do we see there? What do we see? We see the grayish color on the bulk of the implant. So at the time of this implantation, we saw clinically there was a bone on the bulk of it, and 1 year is fine. In 5 years now, what we see, the buccal plate is gone. Buccal plate. Of course, we drilled out the metal space. You put the non-viral metal against the lack of vascularity of the cortical plate. Matter of time, cortical plates appear. This is not peri-implantar. This is a bone physiology of it. But proximally, it's still healthy. It's still healthy. So we went in there. What we end up doing in here is what we learned from literature, right? Rather than augmenting this with bone, which I have done many times, which I no longer do because that paper thin, delicate soft tissue, you elevate that off the implant, you put the dead bone particle underneath, close the, guess what's gonna happen? It's gonna happen day in, day out, that soft tissue is gonna slough off, and that graft will fail. We're gonna result in a situation much worse than what we started with. So today I don't do that. In a healthy situation like that, where we see not peri-implantitis, but bone remodeling due to bone physiology, I'm gonna treat them with the soft tissue. Rather than giving more bone, I'm gonna put a thicker blanket over it to protect what we have. So rather than elevating a flap, here we did a vertical incision vista approach and thickened the soft tissue with the connective tissue. And how this ends up progressing and healing goes, that's how we end up, of course, there's nothing wrong, but here I went little too excited with the augmentation, and you see the little callus of a soft tissue there. But that's how we did. And this is 4 years after, 4 years after the graft, soft tissue graft.
That's impressive.
As you will see, not much has changed that on the implant. Now we are making this case into 6 years now, 6 years now, and we are maintaining case perfectly fine, perfectly fine. So pre-op and post-op, in matter of 4 now getting to 6 years, just by treating that and giving a proper protection, providing a more of a vascularity to that buccal aspect where that bone is compromised, and we are very successful maintaining that. So today we are treating more and more this case with the soft tissue, which has been giving much more predictable outcome than trying to create bone on the surface of a metal which has no vascularity of it. So as we go along, free gingival graft could have been an option, yes, obviously. But again, once you elevate the flap, you expose the implant metal surface of it, and that remaining on the proximal border, very thin layer of bone, you put the free gingival graft over that, your chance of survivability of the graft probably is not as good as the way we approach it as a tunneling, which provide the maximum blood supply to the overlaying
Agree.
soft tissue
Agree.
and to the graft also. So I would not treat that as a free gingiva graft. Right? But again, that is exactly what we see. This case most likely started just like the case I just showed you. At one point was just a thinning of the buccal that we neglected as a clinician because periapical radiograph showed no bone loss, and this is perfectly fine. And come to this point, now we have, what do we do with this? What do we do with this, right? So let's move on. Here is a case that we are looking at two implants on the anterior, right? 7 and 10, so 12 and 22. As you see, the bone loss, massive bone loss on 12. And let's move on. And here is a history of this, right? How we started this case 2006, and we finished this case with the upper reconstruction. We maintained 2006 to 2011, and patient left us. Left us for a very silly reason. I bring these patients back. By the way, there was a question if we are going to talk about hygiene. Probably we won't have enough time to get into the maintenance of it. But the cases like this, we put them in every 3-month hygiene visit, right? The reason this patient left us after 5 years because at that time our hygiene fee was $120 per visit, and talking to a friend of his friend was getting hygiene at the other doctor for $85. So I was very upset because I was charging $35 more than other guy, and he left in 2011.
God.
And he came back in 2016 like this. Would you take me back? Because nobody want to treat me now. So he came back in 2006, and so that's the history of it. So let's go forward and see. Before I get to that part in there, I want to look at this part in here. So this is my implant, and this is an Astra implant. And what we want to see here is this. Let's look at the two anterior implants in there. And if we compare, let's go. The crest of the bone and the position of the implant, you see the unleveling of it, the anterior implant more apical than the posterior one. Both of them pretty much at the crest because the anterior implant was an immediate placement at the time. But as you see, unleveling of it, for me today in 2021, this is absolutely no. No. But if you look at the two posteriors now, let's compare the implant head relative to the crest. And here we see the next one that both implant head is leveled to the crestal bone. And as you see, obvious difference between two anteriors and two posteriors. As I said, two anteriors, that relationship is no. And the way we want to do is the leveling of the implant in there. Why? I have done many of implants unleveled head, and after years of, and those years are usually 4, 5, 6 years. That's when you get to see a sign if I did something right or wrong, right? And I'm going to show you some x-rays on the next slide. And as you see here, these are not mine, and I brought down from Facebook. And the reason of the posting of this x-ray is from different people, was not about what we are talking about in here. But let's look at each one of them. And I'm going to draw some lines in there. As you see, the front one, unlevel the implant and look at where the crest of the bone is located. Look at the second one and third one and the bottom one. Bone end up going to where? To the deeper head of the implant. In other words, the implant that was positioned higher than other one lost the where? To the head of the placed implant. consistently, right? You look at the first one where the bone loss is. Bone loss is down to the level of the deeper implant, right? Look at the 21 compared to 22. And same thing other one, same thing other one. Let's look at the other slide in there. Some more pictures of that, right? Here again, this comes from different people, and the posting was for something else. Nobody mentioned about what we are talking about it, but let's draw some lines in here to see where the implants are. Again, just the way we did. All the unleveled implant, the more coronally positioned implant lost the bone to where? To the head of apically positioned one. It never fails, right? There is one situation that you don't get the bone loss. And I'll get to that. Let's go to the next one in here. And here I'm going to show you a case of mine. And we had a 4-unit bridge going from 44 through 47. And we had a fracture, and so we end up sectioning. Here we're going to restore with the implant in there. Now, where am I going to position the implant? A plan in your own mind. By the way, number 47 is a hopeless, and the reasoning for that is not the point in here, but 47 is hopeless tooth. We're going to replace this area with implants. And hopefully you did your treatment plan in there. In your head, but let's see what we are analyzing here. So here is the blue line. You see the crest of the bone, and let's go one back. Let's go one slide back, one forward. Okay, I think we
am I missing?
Forward. Yeah, I think we are missing one, but it's not important. Okay. That's okay. So let's go to the next one. So blue line is the crest of the bone, right? And then we are positioning two implants. Two implants. Let's show the implants in there. No. Let's go back to the same one. The one is fine.
This one
the
here,
one
okay.
that you showed it. Yeah, that's good, right there. So let's look at the implant. On the left side, we position the head of the implant to the higher level of the bone, which is the mesial aspect of it. As you see, the distal side now is a supraosseous. If I don't like that, and if I want to put the distal side into the bone, of course, the mesial sides are much deeper of it.
That's right. Yeah.
So when we do that, how the bone remodeling will go is how the red line shows on the right side. We are going to have a very abrupt bone loss to the head of the implant on the mesial aspect of the implant 45. And because there's a knife edge crest, we are going to have 0.5 millimeter to 1 millimeter bone loss on the distal side of that, although we place the implant subosseous, right, at the crest. And that is what we don't want to face with, or at least I don't want to face with. Because if I prevent the bone loss on the mesial side, I'm going to have a bone loss on the distal side of that. Why? Because that triangle with the bone remaining is not vascularized enough to survive. Why? Because a metal screw went in there, we drilled out all the marrow volume of the bone where the blood supply comes from. So how am I going to treat this patient? I'm going to treat this patient very differently. Could be very controversial, but I have my own reasoning for that. And I'll show you how we treat that. And if we go to the next one. So here is the situation. So 44, there's a pontic on 45. We're going to section that, of course. And 47 is a hopeless. And the way we treat this, we're going to put the first implant at 46 site. And we extracted 47. We graft the socket. Today, no doubt in my mind that 47 implant will be immediately placed. No doubt in my mind. But at that time, we placed the implant at 46, grafted 47, and later time we went in there, placed the implant at 47 site. What about 45? Let's see what we did on 45 as we show the next one. As you see here, I restored this case, the mesial cantilever of a 3-unit supported by 2 implants in there, right? So first implant 45 and the second implant 47 implants were placed in 2007. And here is a follow-up 2015, 8 years later. You see the maintenance of the bone of those implants 46 and 47. Now it is just done not too long ago in 2020, right? So 13 years later, we are maintaining the bone, the crest to the head of the implant. We didn't get the crest of bone loss, but we lost a tooth 44, and we end up placing a different implant in there, restoring totally different way than how we did back then in 2007. That is the reason why didn't I place one implant at 45 and 47 make a 3-unit bridge? Because we don't want to have a unleveled crestal bone around the implant. We don't want to have a one sitting higher than other one, adjacent implant. True implant in proximity, unleveled vertically, is absolute contraindication according to our protocol. So if that's the case, I'd rather much more have a cantilever bridge, mesial cantilever. Mesial cantilever. I don't do distal cantilever, right? I don't do distal cantilever. Mesial cantilever, one premolar cantilever of posterior implant. I feel very comfortable with that. So having said that, let's go forward and let's go back to that patient who had the bone loss at 12 and 22. So let's look at the focus on number 22. As you see on CBCT, bulk of the implant almost flush to the buccal plate. And we're gonna go and look at this case in a little more detail. And let's go to the next one. And here we see now that a close-up of an implant 22. As you see, clinically very, very thin soft tissue there. And this was a red flag for me. There is a grayish color that I see through the soft tissue. So I know what's going to happen matter of time. So I'm going to treat this. And here is what we did at that time. We went in there. We opened up the flap. As you see, the gray color of the implant body we saw through the soft tissue. But here we see at the more cervical aspect, we still have a very thin remaining bridge of bone, which I guarantee 100% that matter of time we're gonna lose that bridge of bone, and matter of time then bone loss begin to wrap around the implant. That's when we get to see proximal bone loss of periapical. We are gonna diagnose that as a peri-implantitis, and how we're gonna treat that. That implant is coming out, right? So at this time, in anticipation of future peri-implantitis, not from the bacteria or lack of hygiene, but as an origin of a normal bone physiology, right? And we treated that time, as we go forward, as many members of let's keep going, as members of a Biogen Institute love to do, and we've been doing this for quite some time now, and it's my favorite way of doing GBR, which is using sticky bone, right? So we went in there and we did a bone augmentation that I'll show you on my next picture. So the buccal aspect was over grafted with the bone, covered with the PRF membrane over, and we did the closure of that, right? And how this end up turning out, here is at the time of the placement of the final restoration. As you see, the much fibrotic looking, much thicker looking soft tissue on the buccal of implant 22. And let's go forward and see the follow-up of that. That's an insertion of the new bridge there. As you see, the thicker soft tissue compared to that, very thin, flat preoperatively. And I'll show you this on the radiograph now, what it's like before and after. So on the top, as you see, the pre-treatment, and that is after, during follow-up CBCT, amount of the bone augmentation we did using sticky bone. That's how we used to treat it before. And here I was lucky because it was an upper, and the soft tissue is still relatively thick, was not as delicate as the overdenture case in the lower we saw. if case today, again, no doubt in my mind, I'm gonna do the soft tissue augmentation, not hard tissue augmentation, right? I
CTG?
can maintain absolutely, absolutely. And if at all possible, without flap or tunnel, without flap or tunnel. Because once we elevate the flap over that implant metal surface, I would say probably 9.9 out of 10, at least in my hands, end up having recession of a soft
Yes.
tissue.
Yes.
So I'm not going to elevate the flap if I can avoid it.
Mm-hmm.
So the tunneling, not through the sulcus, but it's a much more elegant, easier way, which is a vista, vertical incision, and a much simpler way. But that's how we will treat this case. But as we move on, here is a follow-up of that same case now. In 2017, when we finished the case, treating that number 12 implant, number 22 implant, and we reconstructed again. But look at the posterior side, upper left side, and I'll give a close-up of it. And let's go and look at those implants, the upper left posterior. And here is a full mouth in 2019. And we recently saw this patient after pandemic now in 2020, and absolute no difference, noticeable difference. And I'll give a close-up of those implants now on the next picture. Here we are. Those are the two new implants that we placed. Again, you see the mesial cantilever. We removed that 24 implant that we had, the failing 24 implant. We grafted socket, but instead of placing implant at that site, we end up going the identical site of a 25 and 26. Look at the black line where the crestal bone and the red line is soft tissue. And look at head of the implant position relative to the soft tissue and hard tissue. And that's what we want to talk a little bit about it. Why and what we see here. And as we go, the new concept of not mine, but which I loved it. Not that we were not aware of it, we were suspecting, but there was somebody smarter than us, working ahead of it. When I said the publication came out, bingo,
Yes.
we were not wrong, right? Which is a zero bone loss concept by Linguicius, an umbrella concept by Albert Mizeli from Venezuela. Love the people in here. And what that means is, and to be honest, zero bone loss, I'm not sure if I would say from my cases, but the reason why I say reducing the risk of a bone loss, not necessarily, preventing the bone loss. But as we go, and what are the factors involved in it? It's a multifactorial. It's a of hard tissue, soft tissue, abutment design, abutment material, prosthetic design, prosthetic material, and not only that prosthetic material, but that material surface treatment is different also, right? And one case that we have done many years ago, soon after my training, and this is a treatment of a tooth number 22, I'll show you next, that at this time, we are using external hex 3.75 Brenner Marco implant. At this time, the hottest topic, you remember that?
Yeah, I remember. That's I'm laughing. Yeah. We used a lot of those.
So, the hot topic at that time was a cross-section of the implant was round, cross-section of the CEJ level central inside is a triangle. We need to carve the tissue with the provisional to create an ideal emergency provision. That's what we did. And many my mentors took a copy of that slide at the time. And today I have to say that was wrong. And I don't do that anymore. So here I share with you some of the x-rays that we have. As you see the top, the middle slide, the profile, the contour of the crown and how the crown was modified, right? And I don't want to get into details because that's not the purpose of the gathering today, but many cases that I treated intentionally or unintentionally, I have removed many of my own cases to recontour and to reinsert, as you see on the top and as you see on the bottom there. And as we follow up here in 2017, implant went in there. in 18 the radiograph, right, at the insert.
Mm-hmm.
In 19, I'm removing that
Mm-hmm.
and recontouring, right? We see 2016, now at 2019, after recontouring, where the bone is positioned, crestal bone is relative to the head of the implant. As we move along, let's look at how we are doing it today. These are the recent, more recent X-rays. You look at the diameter of the implant and diameter of the abutment relative to that, and where the bone is positioned. Day in and day out, consistently we are achieving result as we see here, bone growing over the top of the implant.
Yep.
And now we have a follow-up of 4 or 5 years now and successfully maintaining that. And I'll try to summarize that in a little more detail as we move. Here is the same case that we talked about before, right? And let's move. And here we see how we did implant density then. Very proudly, today we are a little bit smarter to self-diagnose that what we did is for this patient was not right or was not good enough, and how we are doing it today. How much change has happened now. Do I feel comfortable that what we are doing today is right? I'm not sure. We'll find out as time goes, right? So as we move on, I can believe I'm into my almost hour 10 minutes talking now. I was supposed to wrap up in 40 minutes, right?
Dr. Kim, don't worry about it. We have a 30 live participant. They don't care how long you take. Take it to the midnight if you have to, because this is very important. I'd rather you spend the time that's needed and make this point important, because I'd rather you take the time to do it rather than rush it and my members wondering what it meant. Because although I know this concept, although just like you, I suspected it. It's the biology has always been there, but we always wonder over the last 25 years after doing 20,000 implants, why am I seeing these patterns? Why am I seeing this? And when Thomas brought in, and what he did was not discovery. What he did was structurally putting those things together into an equation that is digestible and makes sense to a normal human being. And if there's one thing that I would love for us to share with our member is this fundamental concept, so that when they look at their case coming Monday, they're going to change the way they look at things from now on, right? Because this is far more than tips and tricks. To me, people ask me how to be a good implant dentist. I have one word: be a good biologist. Respect the living tissues. So
exactly, absolutely.
Yeah, I mean, sorry to interrupt you, but do not rush it. If these members are past their bedtime, if they need to go to bed, go to bed. I don't care, right? Because I am learning as I speak. This, I'm a selfish way. I'm learning from you, because I don't get to have this kind of opportunity to learn one-on-one from you. So please do it for me, okay? Yeah.
Great.
Go ahead.
Thank you.
Go ahead.
Thank
Yeah,
you.
absolutely.
So as we see here, where the implants are positioned in here relative to the crest, right? Not only that, look at the diameter of the implants and how the behavior of the bone is very different. But despite of that, we are successfully maintaining the bone over the head of the implant. Long run. Definition of long run for today, about 4 or 5 years we are maintaining now. So as we go, let's look at some other X-rays. Here we see one case restored on the left side. The middle slide is not mine. That slide comes from Dental XP actually. Comes from a reader implant they advocate. And that's a healing abutment from reader implant system. And the last X-ray is a very good friend of mine in South Korea. He's a fan of subosseous placement of the implant. Little too much actually for my taste. But despite of that, you see the maintenance of the bone, surrounding the abutments. And I'm not saying that it's an integration to the abutment, but maintenance of that. So the purpose of this healing abutment on the middle slide from retinal implant is exactly the same thing what we are talking about. It's creating space for the bone and blood clot to survive, right? Rather than compressing, we are creating enough of room to eliminate the pressure for the blood clot to maintain and the graft particle and bone survive in there. So let's do a close-up analysis of the X-ray on the left side. Here is you see the implant, you see the bone crest, and you see the red line, which is a soft tissue, right? Soft tissue. And as you see, as we measure distance from head of the implant to the soft tissue on the left side, the implant position 2 millimeter subosseous, where we have a 1 millimeter soft tissue. Middle one, implant was placed at 1 millimeter subosseous, where we have a 2 millimeter of a soft tissue thickness. The most anterior one, implant almost as an osseous crest, where we have a 3 millimeter thickness of soft tissue there. Wow, this is very interesting, right? Why we are creating this discrepancy, one implant deeper than other one. Well, there is a reason why we are doing that. We are measuring the thickness of the soft tissue each site, and based on that, we are determining where the head of the implant should go, right? So as we move to the next one, that's exactly the concept built in. I don't use this implant, but I love the concept because I can't agree better. That's exactly the idea. Rather than compressing that bone and soft tissue at the head of the implant, we are creating a notching and undercut concavity to release the pressure, so there is a maximum blood supply in there. That's the whole philosophy behind. I'm not a user of the system, but I love the idea. So as we move, the reasoning for that is this: the space between gingival margins around the implant osteotomy and implant platform must be maximized, right? So that there's a maximum volume of a blood clot at the time of surgery, minimize the pressure, therefore better survivability of the graft and the living bone. And I'll show you a better picture of that on my next one. And here is two different design of the subgingival contour of abutment. And when we have an opportunity, we'll get into more depth of it. But one of the article mostly quoted internationally, actually, comes from an article published from our graduate from Penn. And this article described critical contour and subcritical contour, meaning the area at the gingival margin level is a very critical contour of the crown, and the close to the implant is a subcritical contour. And although it's from Penn, I take a proudly love the group and my colleagues, but very respectfully I say I don't agree. I don't agree, because subcritical contour is misleading, that it's not important zone. And my point today to you is that zone B, platform switching area, where you see the letter B, which is defined by paper as the paper as a subcritical contour. In my mind, that's a very, very critical contour, because that contour is going to determine either I'm going to maintain the bone at the crest, or I'm going to make that bone to resolve away, right? So if we go to the next one now, if we look at the healing abutment, and this is generally what we see, we have the tissue color and the height of the abutment itself and diameter, right? And I'm going to analyze that in a little different way now on my next one. Until now, it's a healing abutment is healing abutment. You put the healing abutment and let the soft tissue heal. No. Healing abutment next to the surgery time, healing abutment is the next one is gonna determine either the crest of the bone is gonna survive or not.
Yes.
And that has to do with that contour, as you see on the middle one. That design is the one that we use for many, many years. Fairer the better. Fairer the better, because that's gonna open a wider socket. Good emergency profile, good, aesthetic and all. But that type of healing abutment is totally out of my inventory now, because that zone where the blue arrow is showing you is the most critical part. And that is the area that I want to release the pressure
That's
as
right.
much as possible. That is the area that I want to make my healing abutment as skinny as possible. As skinny as possible. Now, wider the implant and narrower the neck of the healing abutment, bigger space I have, better chance I have in maintaining crestal bone. Right? Now, as we go to the next one again, I remember some time ago, the Bytes has shown modification of what I'm going to talk about in here, which is, as you see, the stock abutments, right? Stock abutment, either UCLA abutment, CASAB abutment, or temporary cylinders, they all, from the head of the implant, diverge out.
Yes.
You have that wing,
Yes.
that flare. That flare is within 1 millimeter from the head of the implant.
Yeah.
That is a disaster from beginning. Disaster from beginning. And as you see on the picture on the right side, very first thing I do is get rid of the flare. Get rid of the flare. You gotta trim the flare out, right? So up to at least about half to 1 millimeter max to the gingival margin, everything has to go up as skinny as possible to reduce the pressure on the supracrestal area, which is a very, very critical zone. Very, very critical zone. Okay. So as we go, next one, I'm going to show you an article, a research. It's not just based on gut feeling. As you see, the two different designs of the abutment, the one that we use for a very long time on the right side, that fat healing abutment to create a wide open socket, and more skinnier one, as you see the histology of that. And on the right side, you see the red, which is the bone growing over the head of the implant when that pressure is released to the maximum, right? So what we learn from this is on the next one, as we see, conclusion is that wide and more divergent from main implant, actually implant head, abutment design induce an apical displacement of the peri-implant biology width. Right? In other words, fatter the implant, create more bone loss. Basically, that's the meaning of it, right? In other words, skinnier the abutment neck, better bone volume we have, less chance of bone loss at the crest. So that divergency is the key. Is the key, which we ignored. Actually, we intentionally for many, many years intentionally we diverge the healing abutments and the crown contours. Why? Because we are focusing on aesthetics, ignoring the biology of it.
Yeah.
That's a crime. That's a crime as a clinician, right? Everything is so focused into aesthetic. Right? I want to have a blue eyes too, okay? But I'm not allowed to. That's too bad. That's too bad for me.
Yeah.
But blue eyes on me is gonna look funny, right? Because that violate the basic principles of my phenotype. Right?
It's kind of interesting. Yeah, it's so true because if I want to share is when I was starting with implant system like a BioHorizon back then and also a Nobel, they all had like square type of a healing abutment, and we didn't have much choices of choosing size of healing abutment because back then size of the healing abutment dictated corresponding color coded healing abutment to fit that implant. So that was frustrating, and it always gave us this tomato on a stick type of a profile where you get all this fluid trapping and everything. And then a company came and started to make a stock abutment that is a nice wide, thing. So wow, that's great. I get to choose them. I can block out all this undercut and get rid of the black triangle. In some companies, even make those a custom composite healing abutment that obliterates the whole socket. They come on that. But when I use those years later, I start to see a trend again. I start to lose bone. And so it's almost like a come to the circle about what I've learned in my own cases, having done numerous cases of my own cases. We got to keep the neck as narrow as possible. And there's certain amount of the running room, in my opinion, at least 3 millimeters, minimum 3 millimeters of running room towards the tissue has to be narrow enough before we do an S-curve emergence profile. I've learned from my own mistakes, So I think this part is it may sound fundamental, but I see a lot of clinicians using short, stocky healing abutments and thinking that that's the right size, And I think this lecture here, I think if I were to point out some of the key lecture slides out of today, I think this is very, very important for the members. Go ahead. Go ahead. Continue. Thank you.
So on our next one, let's see what we learned over time. That implant with platform switching did not preserve crestal bone better, right? Today we kind of feel like you gotta have a platform switching, right? If you see the bone loss, because that implant didn't have a platform switching, it's not platform switching. Platform switching is not everything, as the paper said. Platform switching did not preserve bone better compared to implants with traditional without platform switching. When at time of the implant placement, when soft tissue was thin, regardless of we had a crestal bone loss. And on my next one, next paper says that we have one before that.
Hold on a second. Is this one here?
Okay.
Is this the one?
That's the one. Okay. Now let's move to the next one.
Okay.
So you keep telling me that you gotta have a thin bone, thin tissue is not good because regardless of platform switching, you're gonna have bone loss anyway. But what do you want me to do if existing soft tissue is thin? Right? What do you want me to do? Wow, that's not good. And you gotta find a solution for that. And the solution is on my next picture is here. The yellow is the bone, pink is the soft tissue there. So you have an option to solve that issue when you're faced with, very thin soft tissue. Number one, you augment the soft tissue. So you thicken the soft tissue first. Or if that is not an option, then you gotta position the implant deeper subosseous. So if the soft tissue cannot do the work of protecting it, then bone has to come in to help with that, and for that the implant has to go deeper. Why? To maintain, as Dr. Kwan just said, minimum of a 3 millimeter. Minimum 3 millimeter. No, let's go back. Minimum 3 millimeter. So as you see on the left side,
this one. Sorry.
Let's go back. Yes, right here. As we see, minimum of 3 millimeter. So, but more than that, ideally for me, if I can have a 4. Even better, but 3 would be minimal. So if I have a 1 millimeter thick soft tissue, my implant is gonna go 2 millimeter subosseous. If I have a 2 millimeter soft tissue, my implant goes 1 millimeter subosseous. If I have a 3 millimeter or thicker, I can afford to place an implant at the crest. That's the reason why on that X-ray I showed you, 3 implants together, they were positioned at different levels relative to the osseous crest. The key is here. Maintaining proper relationship, preserving the relationship of the soft tissue, hard tissue relative to the implant, and comes the prosthetic component and design to make the even more complicated prosthetic material, to make that worse surface treatment of the prosthetic material. So if I can summarize, I'll show that on my next picture in here. By the way, what we are talking about is as I said, is a one day discussion, and I took about 20% of the material out of there, and I'm trying to focus on 3 main areas. We talk about soft tissue thickness importance, relationship of the soft tissue thickness and subosseous position of the implant, and the prosthetic design of it. Those are the three components. I have many others, as you see on this picture. Each one of those lines, we could spend hours talking about it. Unfortunately, today is not the time for it. But Dr. Kwan, if you want to get into details of these lines, you need to take me back. You need to bring me back.
Right there.
And not online, but I want to visit the beautiful
Absolutely.
town of Vancouver.
Absolutely.
But-
Absolutely.
But as you see, and you know, one day we get to that. But as you see, I give you examples of how we design the prosthetics now, which is very different from before. And let's go to the next one. The prosthetic design, the way we show now, back in early 90s when we started, this was absolutely no. Because at that time we were told that this is a cauliflower, this is no good. You gotta create the wide open socket, so you have a beautiful contour of the kind of emergency from the head of the implant out there. Now we go back in there, as you see on the radiograph. Here are the 46 and 47. And that's how we are designing. We are going to constrict neck of the implant as much as possible. And the divergence of the contour of the anatomy of the canal, we do that about a millimeter from the gingival margin level. That's where we create the contour of it, right? And all that as an attempt to maximize the space at the supraosseous, supracrestal level relative to the head of the implant. We don't want to do a compression to the bone or to the soft tissue, And as we go to the following now, and I'll be wrapping up shortly, but we want to create what we call an S-curve now.
Yes.
Not an S-curve that we know of a beautiful, woman's body, but S-curve which is the very sexy in crown contour that we want to flatten out just about at the gingival margin level and constrict as much as possible in subgingival area, where once we knew as a subcritical contour, and today I tell in my definition, that's a very, very critical contour.
Absolutely.
Very, very critical. That is what is going to determine if the supraosseous level of the bone, supracrestal level relative to the head of the implant, that bone and soft tissue will survive or not, And I'll give you an example that we see on the radiograph, which is the next one, that we exactly the same picture that we see consistently, that bone sitting on the top of the implant and being maintained. And reason is because we are doing our best to respect the biology. And I'll show an example of a case that we do today, how we do today, which is the treatment of a fractured central incisor number 12. As you see in the radial fracture, there is no buccal bone in there. And we're going to plan this as an immediate placement. Here is the day of the surgery now. We extract that tooth. And we should have one picture before this. No, before. We are missing one slide.
Sorry.
It doesn't matter. Yeah, it's not important. We extract the number 11. There was no buccal plate remaining, as we see on the CBCT. We are using extracted tooth, convert that into provisional.
Oh, wow.
There's a screw routine, right? And here is my next picture. How we do next. Here is, by the way, I'm not a keen of a flapless surgery, and I know the implication of the flap. I'm not good enough to the flapless surgery. When I have a flap wide open, I see everything. I screw up. So flapless surgery is not for me. I'm not skilled enough for that. So all my implant surgeries are open flap. On my 20-some years, I think I can count on my one hand how many flapless surgery that I have done. Not saying the flapless is bad. Flapless doesn't work for me. And that's the reason why you see the open flap here. So the provisional going in, again, grafting the missing buccal plate with the sticky bone, covering with the PRF, attempt to protect the bone graft and thickening of the soft tissue. Provisional is under contour on the buccal aspect of it, and here is a healing of that case.
Beautiful.
So here is a healing with the provisional. As you see, the mid buccal of the temporary is sitting farther palatal, releasing enough pressure for the thickening of the soft tissue. As we thicken, we gain the volume of it. As you see, gingival margin of 11 implant sitting much more coronal than number 21. And soft tissues are much thicker on the implant than the natural tooth, as you see the unleveling of it. Now I can afford the luxury of sculpturing that to create the soft tissue architecture that I want to, which I show you next. And here is the provisional that we are modifying the contour of it. Not the way we have done before, as you see on the top, but we want to build in the S-curve to release the pressure on the buccal side of that, right? And by doing that, we level the gingival margin now, buccolingually and apicocoronally. If we go to the next one, here you see the picture of an apicocoronally now on the top before modifying the contour, and on the bottom after, right? Not by removing the soft tissue, but by compressing the soft tissue, just the way we do with the bone, also densification with the denser bone. We don't drill the bone out, but we compress, condense it. So we don't want to cut out the soft tissue, but we want to sculpture that, right? So by doing that, we achieve the soft tissue architecture that we desire. And here is a final case going in on the next one. Here is the verification of the contour of the soft tissue and response of the inner proximal area where the papilla begins to build in. And we build all the information into the abutment, which is next. And here is an old case, so we are using the metal custom abutment. Today we are using more and more of a zirconia abutments. But as you see, the buccal root eminence of the 21 compared to the implant and pretty symmetric and all, and we can achieve that because we built the bone and we thicken the soft tissue, and we are playing with modifying the contour of the restoration. And here is the final case at day of the insert, right? And on the radiography, you see from lack of a buccal plate, amount of the bone that we built, and the quality of the fibrotic nature of the soft tissue we built over there. So combination of all that, giving the result. Looking back this case, one thing that I would have modified even more is I would constrict that subgingival portion of the abutment even more than what we have done, even more than that. So here is a summary of what we did, and what we are doing now, which is the next picture, the same as the one that I showed you before. What we are doing to minimize the crestal bone loss is summarized on my next slide in here, right? And I will show you what we do today. The very first on the left side, the red line, the short arrow, is the marrow space between implant and bone. The beige you see, the thick beige you see in the middle of the bone, that is the partial extraction therapy, like a socket shift.
Right here.
And the thickness of the bone over the socket shield, which you will see right the left to it, and then the thickness of the soft tissue, right? That blue line, the turquoise line, is the diameter of the implant. I used to be a fan of a 6 millimeter implant. Today I don't do that. My implant diameter goes from 3.1 to 5 millimeter max. We started with the 3.75 was the original brand mark implant. From there, we went to 4 millimeter, 4.5, 5, 6, 7, 8, and you name it. Today, I'm back. I'm back to 20 years ago. My go-to implant is a 4 millimeter diameter. On the molar, I place a 5 millimeter. Very, 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 very rare for me to use implant any wider than 5 millimeter, because any wider than that, I'm removing more of a metal space, right? The green line is the diameter design of the prosthetic. Red dot is a material of the prosthetic. The dark blue on the left side is dark blue right there. That is what they call as a subcritical contour, which for me biologically is a very, very critical contour. And the pink line on the crown and the buckle is where I'm gonna create my divergency, which is usually about a millimeter within the millimeter of the gingival margin level. On the lingual side of that is a treatment of the prosthetic material. It's the same material I'm gonna use, which is a zirconia, but the red line, which is a subgingival portion, I'm gonna treat that surface different from that black line you see on the lingual side, which is a more coronal, the gingival margin level. I'm gonna treat the zirconia surface very differently for biologic reason. And hopefully we'll have an opportunity to get together for us to review that. But on my next one is where I get bothered the most. Again, this comes from social media, and I really get sick when I get to see bone being chopped down, as you see on the pre-op pan. If we look at the premolar, they seem to have pretty decent bone level. Chopping down the volume of the bone so we can do all one force as we see. But let's look at the arrows there on the left side to the right side. All of them, the buccal bone on those implants are paper thin. And we don't need to, at this point, we know exactly what is going to happen with that bone, the buccal plate on the buccal side of those implants. And whoever was the doctor in here trying to be smart, and they are adding alloderm in there, as you see on the implant 43 site in there. But you know what? That's not how you manage the soft tissue, right? This is a picture of the surgery. They don't show how the soft tissue healed. I guarantee that alloderm has sloughed because that soft tissue management is very poor. I mean, this is not good enough, right? This is not good enough on my definition in there. And as we see a close-up of that on my on the next picture, and we see this day in and day out in our social media, very proudly posting, and so many people braving how wonderful this is. And we know it is not. We know it is not. And the picture that we saw before on the start of it, on my next one, that even the laboratory, even the vendors posting a picture that biologically, physiologically, or maybe I could say even ethically is not acceptable design of rigid lab, which access for hygiene is just impossible. All this end up resulting in something like this. Drop that gorgeous prosthetic work, biological disaster. A patient who we went in there, chopped down the bone, and to do 0-4 and give it this type of restoration, billing them tons of money, now face a situation like this. Who and what are we gonna do for this patient? Even a conventional food actually is not indicated, not wearable here, not wearable. And it's bad, sad reality that we are living It really sad reality. And the hot topic today in dentistry
Yeah.
is how to treat peri-implantitis. And I'm going to give you an answer to that. And I'm going to give you an answer to that. How to treat peri-implantitis, right? And on the following one, I make a summary of it, right? Summary of what we do. Peri-implantitis, there's a whole lot of factors in there. It's not just a peri-apical bone loss in there. It's just not peri. There's a whole lot that we need to analyze. And here is the question. Here is a question, right? That everybody asks here, that how to manage peri-implantitis. And my title to what to do to prevent or to reduce crestal bone loss. On my next slide here is my favorite, that two slide that I never put aside. Get inspired and wrong is wrong, even if everybody's doing it. And right is right, even if no one is doing it, right? No one is doing it. And let's go back to the title of the that we saw 2 hours ago now. And the title was How to Prevent Crestal Bone Loss and Peri-implantitis. And I'm going to give you the answer, right? I'm going to give you the answer. And 100% accurate answer as far as I'm concerned. And the answer is right here. It's the prevention. Don't try to treat peri-implantitis. Try to prevent the peri-implantitis. And that is the key. That is the key. Right? That is the key.
Absolutely.
The material and technique to treat peri-implantitis, today, there is none that is a consistently predictable, successful outcome. There is none out there. There is none out there. So let's not get into peri-implantitis. And within certain limitations, I think we know a little bit more than what we knew, 4 or 5 years ago, that we can prevent that a little bit better than what we did before, right? And I was born in Korea, and I was educated as a Korean. And in Korea, there is a saying, there's a word that's called choshin, right? And you can read it the way I wrote down choshin. The meaning of that is a beginner's mind. Beginner's mind. You know why we get into trouble as a clinician? It's an arrogance. Arrogance. We think that we know too much. That we think that we know everything, right? That's the beginning. That's the beginning. When my boys began driving, I told my wife, for the next 6 months, I'm not worried about it. I'm not worried about it. They're not going to get into an accident. When they're going to get into an accident? After 6 months.
Yeah.
Why? Because they think now they can drive, right? One hand out there on the window, holding one, right? You know why? Because you get arrogant, right? You get arrogant. And we as a clinician, we get arrogant. We become arrogant because we lose choshin. We lose the beginner's mind. We think that we are good. And we know, and we are not. We are not. And who pays the price for it? Another human being right there sitting in front of us, paying tons of money to us. They are the ones paying the price. Financial, emotional, biological, and everything else, right? And as my closing slide is the one that I started with, let's get inspired. Let's continue to share, what experience we learned, right? Good and bad. We inspire each other, and hopefully we get better today than tomorrow than how we are today. Hopefully we are doing a little better than how we did yesterday. I wish I'm sorry for taking 4 times more than time that was allowed, but I had a whole lot more that I could share, and hopefully one day we can get together and help each other, share each other, try to make us a little bit better than who we are today. And thank you very, very much for staying with me, and the wonderful opportunity for to be able to share the humble material we have. And Bike Institute, I love you all, and
I gotta
looking
say
forward to
something.
meeting.
I gotta say something. I know there's a reason why I followed Dr. Kim's teaching. Um, Like when an experienced clinician like myself, when I go on a social media, I can tell you right now, 90%, 95% is all air, all fluff. But once in a while, I'll come across a go-to clinician uh, who knows, who talks the talk, walks the walk, and he doesn't have to boast about it, and he just states what is true. And I can see through that. That's why I've been following him and requesting to share some of his incredible years of knowledge with our group and also me. Because as much as I enjoy teaching, I love learning even more. And Choshim is also part of my learning process as well. I was the most arrogant probably when I started to do about 1,000 implant. And then I started to see my own failures and I started to become humble, how little I know. And even today, as much as I love to share what I know, I also know I don't know everything. And I am okay to say that I made mistakes because I do, and that's how I've learned. And I'm not the best surgeon, I know that, but I'm always being humble by somebody like Dr. Kim. If Dr. Kim, who's so advanced, and if he's humble, what am I to say? So I want to take this opportunity for all our entire group who stayed up, and I would love to keep him for another 2 hours and pick his brain too. But he's given so much more than he had agreed to do with me. So I'm very, very grateful, Dr. Kim. It was a truly an honor. Truly an honor, and absolutely once this pandemic thing is over, you're going to be on my top of the list to bring you to my home, the strong north, Canada, because the world needs to know. What are we to know? Somebody like you who speak the truth. Not pushed by implant companies or by materials company, but somebody who with experience and who's dedicated, but also who's specialized and legitimate academically so sound. And it's been a wonderful, wonderful evening. So everybody who's staying there, please shoot him hard, shoot him likes, okay? He deserves a great hug. And Dr. Kim, thank you so much. I know it's close to midnight in the city of Philadelphia, but once again, from the bottom of my heart, thank you very much, and I wish you a wonderful, great evening. Thank you very much, Dr. Kim. Thank you. Everybody give up love. Everybody, okay? All right, we're going to...
Bye-bye. Looking forward to our next gathering.
Thank you. Thank you very much. Thank you very much. And I am going to go right here now. Okay. All right, guys. Today, you guys get 2C credit, okay? 2C credit for sure, okay? 2C credit for sure, okay? I've learned so much. And I needed this. And, we can all agree to disagree. And, depending on what curve of your journey in implantology is, what you know is what you know. But we always have to stay humble so that we don't fill our bottle with arrogance, right? We need to empty some of our arrogance out so that we can, put some truth into here. And some of the cases he's shown implant failures, some of my cases are like that. A lot of my all-on-4s. I've done over 1,000 of all-on-4 concept, and in the next 2 sessions later on, I'm going to share with you some of my failures for full arches because it's important. It is very controversial. But I have to also speak the truth as well. So in 2 episodes later, I'm going to do that. Next week episode is going to be by some friend from Pennsylvania. Richard is going to share his journey in 3D digital printing, how he started to learn about 3D printing. So we're gonna turn the topic over a little bit and something more technical and digital. Let's do that. But anyways, I really appreciate all you guys staying up as much as you guys are tired, especially those who are joining from the East Coast in the Toronto and Philadelphia area. I really appreciate it. Learning, there's no boundary. GP, especially, it don't matter. At the end, we try to be a good dentist and provide the best quality care that we can for the patient. So thank you very much. And you guys have a wonderful... Now, shout out again. You want CE credit. And today's verification code is this right here. Verification code, which is, okay, LCS 021 YK Kim. LCS 021 YK Kim. Okay, so submit that email, attention to Grace, and then they'll issue AGD CE certificate of 2C credit for tonight. Okay, you guys, love you all. All right, stay healthy, and someday I really hope to meet all of you in person. See you. Good night. Bye bye.
We had our ups and downs, baby. Sometimes we were tight, and sometimes oceans apart. Gotta learn just how to move on without you. Move on without you. We had our on and offs, baby. Sometimes we were tight, and sometimes everything but. Gotta learn just how to forget about you. Forget about you. We had our ups and downs, baby. Sometimes we were tight, and sometimes oceans apart. Gotta learn just how to move on without you. Move on without you.